Hello everyone, this is Arianne Bolivar for Research Applications 2 for Ontario Tech University. Today we will be discussing the efficacy of medical cannabis versus oral opioids in adult palliative pain management. Today's outline will be the research question, background, objectives, study design, which includes selection criteria, recruitment, and measurements, statistical issues, ethical issues, and limitations of research. Research question. So, in adult palliative patients, is medical cannabis more effective in pain management compared to oral opioid medications? The problem. So, opioid medications have been the gold standard in treating different types of pain, especially in palliative medicine. However, there's currently an opioid crisis in North America. So what led to this crisis? Well, the pharmaceutical and healthcare industries in North America have been poorly and insufficiently regulated, which resulted in an increase of opioid prescriptions. And it was mainly driven by profit. So here are some statistics. In the US, in the year 2019, they've resulted in 560 million to 635 million in reduced work productivity, sick time, medication expenses, and medical care in the US. And in 2020, due to opioid overdose, there were 70,000 deaths in the US and 6,300 deaths in Canada. And I'm sure with the pandemic, the numbers for 2021 may have unfortunately risen. And lastly, 1 of every 550 chronic opioid users die within approximately 2.5 years of their first opioid prescription. So what are opioids exactly? So they are a class of drugs derived from the opium poppy plant. They bind to the receptors in the brain and in the central and peripheral nervous systems and help block pain signals. Opioid medications are not only clinically effective, but they are cost effective, and usually they're well tolerated. Opioids help us feel relaxed and happy. They give you that feeling of euphoria, and it can easily result in addiction and misuse of them. The use of opioids also comes with some notable side effects. So with the good comes with the bad, and the side effects are respiratory depression, confusion, sedation, constipation, nausea, vomiting, and dizziness. There are 3 types of opioids: natural, synthetic, and semi-synthetic. Natural opioids are, as we know, morphine and codeine, some examples. Synthetic opioids, they are man-made in the lab. Some examples are tramadol, methadone, and fentanyl. And semi-synthetic opioids are made in the lab, but with natural opiates, so from the plant. And the examples are hydromorphone, hydrocodone, and oxycodone. So what is cannabis? Cannabis is from the cannabis sativa plant, and it has a lot of phytochemicals, but the 2 main phytochemicals are tetrahydrocannabinol, which is THC, and cannabidiol, which is CBD. THC is the component that causes the psychoactive effects, it also helps with muscle relaxation. It is an antiemetic. It simulates appetite and is also anti-inflammatory. CBD, on the other hand, does not cause psychoactive effects, and it's mainly used for pain relief. It inhibits a hormone that is produced in response to injury or inflammation. CBD also possesses anticonvulsant, anti-inflammatory, anxiolytic, so it reduces anxiety, antipsychotic, and neuroprotective effects. So neuroprotective effects it can inhibit neuron cell death or injury. Cannabis is currently being used to treat seizures, digestive issues such as appetite loss or Crohn's, multiple sclerosis, HIV/AIDS, epilepsy, and more. However, there's not enough research in palliative medicine, and 70 to 90% of palliative patients experience moderate to severe chronic pain. The gold standard, like I mentioned before, is usually opioids. However, given the crisis and the negative side effects, alternative medicine is being considered. So we keep talking about palliative care. So what is palliative care? Palliative care refers to non-hospice care offered for patients with serious disease or terminal illness, and it may be given along with life-prolonging or curative treatment. Most palliative clients have cancer, but as I mentioned, it can be any serious or terminal illness. And the main focus of palliative care is to improve the overall quality of life. And usually with palliative care, it's pain and symptom management. So making sure the client is as comfortable as possible. Palliative care is also patient-centered, where healthcare practitioners involve the client in the decision-making and care planning process. And this can involve in advanced directives, DNR, so do not resuscitate, any other wishes by the client. Could be religious or cultural. And lastly, palliative care looks at the client holistically, meaning in all aspects, such as spiritual, mental, emotional, financial, psychological, and social. Now, a client can still receive palliative care at the moment of diagnosis and during any active treatment. So that could be during chemo or radiation. So past studies. So by Pritchard et al., the effect of cannabis on opioid use in patients with cancer receiving palliative care. So this study was a retrospective cohort study, and it was conducted with palliative patients from baseline to follow up after 84 days. The control group were 61 participants, and they were prescribed only opioid medication, while in the experimental group, there were 22 participants, and they were prescribed both opioids and medical cannabis. So the issue with this study is there were an uneven number of participants in each group, and also the titration methods of the clinicians in both groups were not consistent, so it was not effective. In the study by Shin et al., an integrated review of cannabis and cannabinoids in adult oncologic pain management, so they examined 9 articles on the effect of THC on cancer pain. So the studies were from foreign countries, but they all had one common issue, which was the sample sizes were always limited. So for example, one of the studies had indicated 24% of their sample had passed due to time and other factors unrelated to the study. Another study, 32 and 20.6% in study 1, and in study 2, 24.3 and 14.6% have all withdrawn, so it wasn't effective. There has been an increase in interest and use of medical cannabis after its legalization. However, even though there has been a rise in the conversation of medical cannabis, there is still little evidence in palliative pain management. So we want to know if medical cannabis alone is effective in managing the pain for palliative patients. Past studies have indicated that there isn't enough research due to the policies surrounding cannabis research, low and inconsistent sample sizes, and high study withdrawal rates. So we want to have a broader sample population, as well as to educate patients and help bridge the gap on the stigma of medical cannabis. For study design, we would like to conduct a prospective cohort study. There will be an exposure group, which is medical cannabis, versus non-exposure group, which is opioids only. We want to aim for around 60 to 80 participants in each group. There will be periodic follow-ups, which are monthly, and surveys and logs will be used to collect information. For selection criteria, inclusions include palliative adults, men and women aged 18 years and older who suffer from chronic pain for at least 1 year. They have to be in the care of an outpatient oncology clinic or pain clinic, or those receiving palliative care services in the community, such as their homes or retirement homes. Patients who have been consistent on opioids for at least 1 year. Exclusions include those who are cognitively impaired, patients who've had a history of substance abuse, anyone who is chair-fast or bedridden, who have a history of small intestine and liver issues. Now, these areas are important in drug metabolism, so the therapeutic effect of the drugs will not be fully achieved. And lastly, unfortunately, anyone who has a language barrier. For recruitment, letters and emails will be sent out to any management and directors of acute care hospitals, outpatient clinics, retirement homes, and in the community through the local health integration network. So they organize all the community care access. And the letters and emails will include consent, study details, and information of the researchers. So the exposure group is medical cannabis only. Non-exposure group is opioids only. And the main outcome will hopefully be a decrease in dosage of oral opioids. The patient will keep a daily log of opioid intake or cannabis intake, their pain level at the time, pain characteristics, and pain relief duration. Based on our findings, we will be calculating relative risk to see if there will be a reduction in oral opioid use. Ethical issues. We want to ensure privacy and confidentiality at all times. There will be no patient identifiers. In the study, numbers and letters will be used as identifiers. The participants will receive full disclosure, so the benefits and risks involved in the study, so they can make informed decisions. Aside from the subject's initial consent, ongoing consent will be obtained throughout the study. We also need to address any inequalities and try to eliminate any unnecessary harm towards the participants. We also need to respect the decisions of the participants. And we need to understand that things can change over time. They may change their mind, etc. All the data in the study will be stored in a secured hard drive. The files will be password protected and encrypted, and only the researchers are the only ones with access to this hard drive. And lastly, we will consult the ethics board of the institutions as needed if any other ethical issues arise throughout the study. Limitations of research. There may be a challenge in willing participants as medical cannabis still has a stigma. Generally speaking, most palliative patients are older adults who may have the same views even though cannabis is legalized. There could be a challenge in sample size due to this. Education will need to be provided by the researchers, and resources will be given to address ongoing questions and concerns. Researchers will need to partner with experts in the cannabis field. The validity of results can also be affected by loss to follow-up. Some patients in the middle of the study may pass away or choose to withdraw from the study. There may be a challenge as well in getting the approval of the ethics board of the institutions. So the researchers will have to really abide by the Tri-Council Policy Statement 2 guidelines. And that concludes the presentation. Thank you for your time.